You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for April 17th, 2020. The virus continues to dominate the news, all news, so it will be tone deaf and silly to speak on anything else. First, the U.S. numbers. When I recorded last week, there were 500,000 COVID-19 cases. Today, there are approximately 675,000 cases, and that is interesting. The rate of rise 2 weeks ago was threefold. Last week, it was twofold. And this week, it is only 1.35 times greater, and that is good, especially since we are testing more. The death numbers also tell an upbeat story. When I recorded last week, there were 16,000 deaths in the U.S. Today, there were 14,000 more for a total of about 29,900. Now that sounds bad, but the rate of rise 2 weeks ago was fivefold. Last week, about threefold, and this week, the rate of rise is less than twofold at 1.8. Let me repeat, the rate of rise of death is falling by a lot, and that is good news. Social distancing surely is slowing the rate of rise of new cases, but I think the decreasing slope of death comes from more than just distancing, and it may have to do with our learning curve for these patients, and I will speculate more on that later. Stay tuned. Worldwide, we now have more than 2.2 million COVID cases, 145,000 deaths, but almost 600,000 people are known to be recovered. That's almost double the number from last week. Also upbeat news. Now, first, some news on epidemiology. I'm not going to talk about models. They're too hard for me to understand. We have actually some data to discuss. Study number 1 is a report in a New England Journal on screening 210 women presenting for delivery in New York Presbyterian Hospital. This was between March 22nd and April 4th, and they found that 13.5% of these women tested positive on PCR from a nasal swab. Only 4 of the 210 women had symptoms. 98% who tested positive had no symptoms. Now, excluding the symptomatic cases, I find it striking that 1 in 6 women with virus in their nose had no symptoms. On the surface, this means there is a tremendous amount of virus in the community. And of course, that informs the denominator, and if the denominator is larger, then the infection fatality rate is lower. But of course, there are caveats to this study. New York is clearly the most affected city, and a high infection rate there may not translate to other places. Also, without follow-up, over time, we don't know how many of these 13% of asymptomatic cases will turn symptomatic. Surely some of them will. Second study in epidemiology. I looked up the most recent data on the best controlled experiment we have yet. That is the Diamond Princess cruise, where 712 of 3,700 passengers tested positive. The death rate has now increased to about 1.8%, but the last reference that I found on Wikipedia showed that there were 410 asymptomatic cases. So if you're conservative, that means about half of the cases there were also asymptomatic. Study 3. There was also a University of Bonn study from the city of Gangelt, Germany, which found that 2% of 1,000 residents had virus in their nose and 14% had antibodies. Now, that prevalence led investigators to estimate a death rate there of 0.37% overall. Fourth study. New England Journal of Medicine also published a study from Iceland, in which a total of 6% of the population were screened. As of April 4th, 13.3% of people recruited for target testing. Now, this was due to either symptoms or travel to a high-risk country or contact from a positive case tested positive for the virus, nasal pharyngeal swabs. Of those tested in the general population, 0.8% in an open invitation screening and 0.6% in the random population screening tested positive for the virus. Now that seems encouraging to me because the percent of the population with virus on a given day is quite high. Antibody testing would surely be higher as the virus was first found in Iceland in February. And so putting this together, I found a tweet, and I'll link to it, from a Harvard epidemiologist named Michael Mina, M-I-N-A. And he looked at the data on the ground in the U.S., and in the least vulnerable category, the less than 55-year-old category, he noted that there were 877 deaths in that group in the U.S., and there are 231 million people in that age category. So Dr. Mina calculated the IFR, the infection fatality rate, for different assumptions of the percent of people infected. If 1% of this group of less than 55-year-old is infected with the virus, the infection fatality rate is 0.037%. If 10% of this group is infected, like it is in New York City, the infection fatality rate is 0.0037%. Now, don't get mad at me, because last week I mentioned the John Unides preprint from medRxives, in which he and co-authors looked at COVID deaths from highly affected cities, countries, and states which had data available. And they found that the absolute risk of COVID-19 death ranged from 1.7 per million for people less than 65 years old in Germany to 79 per million in New York City. I mention this data because this week the conversation in Washington, on social media, and in think tanks such as Scott Gottlieb's American Enterprise Institute, and in the heartland of our country, specifically Ohio, people are talking about reopening the economy. And when I say economy, that is a euphemism for real people. I am an EP doctor, so I don't have the best plan for reopening. But it seems instructive to me to think about the virus from the point of view of a couple who has 3 children and they've just lost their jobs. The kids are not at school, they're home, so there's no child care. There's no money to buy food, pay rent, and if you tell these people their chance of dying from COVID is 0.037%, regular thinking people are going to wonder about things. I've already had multiple very ill patients call into my office and say they had to stop their cardiac medicines because they have lost their job and health insurance. Second topic, the acute management of patients with pneumonia from COVID. Now, I have been fascinated and literally entranced with the pulmonary issues surrounding COVID-19. Relearning pulmonary physiology has made me dream about going back and doing an ICU fellowship. This is really cool stuff. Now, you know the basic narrative. Early observations from China, then Italy, then the U.S. have all described a so-called happy hypoxemia COVID-19 patient. In other words, the patient has a profoundly low O2 saturation but is still talking, is not tachycardic, and the patient may only be mild to moderately tachypnic. Early on, there was a move to intubate these patients early, perhaps for staff safety reasons and because reports these patients could crash quickly. My ICU colleague here told me of a story in which he had to tell a patient to stop FaceTiming with his family because it was time to intubate. I couldn't believe it, but then the New York Times had a story this week in which a doctor in New York described the exact same kind of madness. But the weirdness does not stop with intubating patients who seem minimally symptomatic. When these happy hypoxemic patients were intubated, they were not like typical ARDS patients, at least early on. They had normal lung compliance. They could be ventilated with normal lung pressures. And here's the problem my ICU colleague explained to me. The protocols for ARDS call for low tidal volumes and dialing up PEEP to keep oxygen levels up. That is the evidence. But then these COVID patients with previously normal lungs and normal lung compliance develop severe air hunger. They struggle on the vent, and that distress causes ICU nurses to call the ICU doctor, and patients end up heavily sedated and some even paralyzed. Many doctors worried about the cascade of iatrogenesis from this process. You recall that young Dr. Cameron Kyle Seidel, who had to take to YouTube to explain his worries. Then the EM crit and pulmonary crit blogging crowd started talking about how these patients were different and previous evidence may not apply so rigidly to these patients. Well, this week, the concerns of these frontline workers were all validated from Dr. Michael Tobin. Now, basically, Dr. Tobin is the Eugene Brunwald of ICU and pulmonary medicine, who wrote one of the most remarkable 1,200-word essays on treating COVID-19. This piece was published in the American Journal of Respiratory and Critical Care Medicine. I'll link to it. It's a masterpiece. It's called Basic Respiratory Management of Coronavirus on Physiologic Principles. I've read it like 5 times. He discusses the fact that hypoxemia can be well tolerated for longer than is recognized, and in patients with decreased oxygen delivery, oxygen extraction initially increases and oxygen consumption remains normal. He also notes that tachypnea in isolation should rarely be the reason to intubate, and that it is incorrect to regard tachypnea as a sign of increased work of breathing alone. And pulmonary infiltrates are common with COVID, and on their own are not an indication for intubation. And finally, beautifully, this quote, mechanical ventilation in and of itself does not produce lung healing. It merely keeps patients alive until their own biological mechanisms are able to outwit the virus. The best way to minimize ventilator-associated complications is to avoid intubation unless it is absolutely necessary. And the surest way to increase COVID-19 mortality is liberal use of intubation and mechanical ventilation. Look, few people listened to young Cameron when he voiced these concerns. He did fare better than Galileo did, but he was still kicked out of the ICU. So kudos to Dr. White and Medscape for getting him on the site. This week saw vast coverage of ventilator overuse in the mainstream media, the Times, Stat, NPR, The Telegraph, and Liam Davenport had another Medscape piece on it. Now, of course, you know that this topic pushes my buttons because A, it was discovered by astute clinicians mostly from the emergency medicine community. B, it involves a conservative approach to an invasive, aggressive procedure. And C, mostly, remember, the most important part of evidence-based medicine is figuring out where evidence applies. It was and is now clear that COVID-19 is not typical ARDS, at least early on, and thus thinking is critical. David Sackett's diagram, remember, includes the intersection of relevant evidence and clinical judgment. My hope here is that the push to avoid mechanical ventilation with permissive hypoxemia, use of higher doses of nasal cannula oxygen, non-invasive ventilation, and awake proning, for instance, will improve the mortality of patients with COVID-19 by reducing iatrogenesis. The learning curve is also good news. Now, third topic, briefly, is anticoagulation. There was a lot of talk this week on the thrombotic issues surrounding COVID-19. On ICU podcasts and in blogs, I've heard docs talking about clotting of lines, abnormalities of clotting assays, and pulmonary emboli. And from the beginning, we have all seen elevations of the D-dimer, which is a biomarker of activation of the clotting system. This is no surprise because huge inflammatory states can and will induce the coagulation system. There was even a case in the New England Journal of Medicine of coagulopathy and antiphospholipid antibodies. This has raised many issues about how best to use anticoagulation. I've seen observational studies with different regimens, but it seems to me this is the perfect place for rapid, pragmatic clinical trials, and I hope these are done and will surely lead to important information. Final topic is on viral therapeutics. First, the hydroxychloroquine and azithromycin issue. Now, you know that the French paper has now been given a mark of concern, not quite retraction, by the International Society of Antimicrobial Chemotherapy. This week, as reported by Ivan Oransky on Retraction Watch, the giant in publishing Elsevier has also expressed concern, quote, at present, additional independent peer review is ongoing to ascertain whether concerns about the research content of this paper have merit. The study authors have been contacted and asked to address the concerns. Depending on the nature of their response, a correction to the scientific record may be considered in accordance with the policies of Elsevier. Yesterday, Medscape reported on a Chinese RCT involving 150 patients with COVID-19 that found no benefit of the hydroxychloroquine, but also a higher rate of adverse events. And earlier in the week, a small study in Brazil was stopped early for significant QT prolongation in the hydroxychloroquine group. It is not remotely controversial to doubt that this regimen will be effective. And when inefficacy is shown, we must never look away at the thousands of doctors and hospitals that use this regimen like Skittles based on the French report, which could be more accurately called an unstudy rather than a study. Now then there is remdesivir. Last weekend, the New England Journal of Medicine published what Daryl Francis from London called half a study. It was a report on 61 patients with COVID-19 who received remdesivir for compassionate use. 8 patients went missing from the data, and the uncontrolled report found that clinical improvement was observed in 36 of 53 patients. This, of course, was lauded in the media and online. Though the authors called for proper RCTs, this paper was widely panned on social media as meaningless because without a control arm, you can't tell how many of these patients would have improved with standard of care. In fact, the currently ongoing Gilead-sponsored remdesivir trial is open label and does not contain a placebo arm. I wrote a column. It was in the form of a letter to Gilead asking them to amend the protocol and allow for a placebo infusion and then a proper control group so that the results of their trial are not biased. Now, they probably won't read or listen to it, but I hope you take a look at the letter. It is quite a short letter. What's more, just hours ago last night, a webcast from the University of Chicago was leaked to the media. In this webcast, Dr. Kathleen Mullane, the University of Chicago infectious disease specialist overseeing the remdesivir studies for the hospital, said that University of Chicago recruited 125 people with COVID-19 into Gilead's 2 phase 3 clinical trials, and 113 patients had severe disease. As per reported on Stat News, she was recorded as saying, quote, "The best news is that most of our patients have already been discharged, which is great. We've only had 2 patients perish." This sent Gilead stock soaring in after-hours trading. Well, you all know that this is hardly useful scientific data. Sadly, the Gilead studies without a proper control are unlikely to yield any useful results, as these anecdotes are also completely useless as you don't have a control group. Now, fortunately, there will be an NIH-funded study of remdesivir. The study is placebo-controlled. Of course, with these leaked anecdotes and publications of half studies, you wonder whether people will want to be randomized. This could affect the ability to get people into trials. And of course, Medscape has a very nice news piece on that important issue. And so that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please tell a friend, consider subscribing, or give us a rating on the app so that others can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.